All right, this is how you solve a case study the AMCI way. I'm Mrs. J. I'm the curriculum director at AMCI. Let's get started. Here are the steps to solve a case study. Okay, at AMCI, our students are instructed on how to select the keywords, how to highlight those keywords. So this case study exercise and these steps are pertinent to when you have completed the keyword highlighting of the keyword process. So just keep in mind, if you've already highlighted your keywords, this is what you'll need to do. Number one, inventory or document, write down. And if you don't want to write, you can highlight all procedures, diagnoses, signs, and symptoms. Number two, go ahead and select the principal procedure. However, if this is an operative report, if you're coding from an operative report on your exam, you'll need to make sure that you document or highlight the following: how the surgical site was entered or accessed, or how that patient was lying. Sometimes your code selection may be um, depend on that information. Also, highlight or document if the procedure was opened or closed or any additional procedures. Number four, select your first listed ICD-10 CM code using the AMCI first listed selection chart in your MCG manual if you need it, or just go ahead and select the first listed code and select the secondary codes. And finally, apply all guidelines. That's it. So that might seem like a lot, but now it's time to put it into play, all of these guidelines. Our preoperative diagnosis, paniculus, diastasis recti. So those are two diagnoses. The postoperative diagnoses are the same. The procedure performed, abdominoplasty. Anesthesia, general. Clinical note: the patient has had multiple pregnancies with diastasis recti occurring with the last pregnancy. She has had long-term problems with low back pain and constipation because of the diastasis recti, to the point where child care and everyday activities are limited. Since having her last child, she has also developed a pannus, causing significant chafing and irritation, which at times results in bleeding and infection. She is here today for the above procedure. She understood the potential risks and complications, including the risks of anesthesia, bleeding, infection, wound healing problems, unfavorable scarring, and potential need for secondary surgery. She wanted to proceed. She also understood the possibility of impaired circulation to the flaps and hematoma, seroma formation. Procedure in detail. The patient was placed on the operating table in supine position. General anesthesia was induced. The abdomen was prepped and draped in the usual sterile fashion and marked for abdominoplasty along the suprapubic natural skin crease. The course, this coursed 36 centimeters in total. The umbilicus was also marked, and the area was infiltrated with 100 cc's of 0.5% xylocaine with 1 to 200,000 epinephrine. After adrenaline effect, the incision was made. The flap was elevated to the umbilicus. The umbilicus was circumscribed and dissected free, with care taken to maintain a generous vascular stalk. Dissection was then taken to the subcostal margin as it tapered superiorly and narrowed with the exposure. Hemostasis was obtained by electrocautery. There was still a lot of skin laxity, and it appeared that an ellipse of skin could be removed through the superior margin of the umbilicus. The flap was incised at the midline for greater exposure. She had significant diastasis recti, which was closed with interrupted mattress sutures of 0 ethibond, followed by a running suture of 0 ethibond. She was placed in semi-flex position, and the ellipse of skin was excised to the superior margin of the umbilicus in the midline. This gave an easy fit for the flap without undue tension. The number 15 drains were placed through the Mons area and secured with 3-0 proline. The skin was then closed at scarpa fascia with sutures of 2-0 PDS. The umbilicus site was marked and a disc of skin was removed. The umbilicus was delivered and sutured with dermal sutures of 4-0 PDS, and the skin with 5-0 fast absorbing plain gut. Deep dermal repair was completed with reasonable staples, and the skin was closed with a subticular suture of 4-0 PDS. Steri-strips were applied over mastisol, an abdominal binder was placed, the patient was awakened, extubated, and transferred to the recovery room in satisfactory condition. There were no operative or aesthetic complications. Estimated blood loss was less than 30 cc's. What are the CPT and ICD-10-CM codes reported for this encounter? Okay, so that was quite lengthy to read. So what do we do now? At the top right, we have our we have what we need to do, but remember, we don't start this process until we've highlighted our keywords. So let's go ahead and do that. Paniculus, diastasis recti, abdominoplasty, multiple pregnancies, diastasis recti occurring with the last pregnancy. Just want you to note that. Patient has low back pain, constipation, chafing, irritation, bleeding, and infection. The patient was lying in supine position. An incision was made. That's a procedure, correct? Disc of skin was removed. Deep dermal repair. I believe that's it. So now we can begin with our steps. Up at the top, we're going to have to inventory or document, and I like to write them down while we're learning, all procedures, diagnoses, signs, and symptoms. Now that we've highlighted our key terms, we can begin with the steps, and they're placed on the upper right of your screen, and that is inventory. While we're learning, I like for us to write down or document as opposed to just highlighting. When you become more advanced, you can just highlight. But for now, we're going to inventory all procedures, diagnoses, signs, and symptoms. And what I'd like to do is separate the procedures from the signs and symptoms and diagnoses. So first, we'll document those procedures. And so far, I just see an abdominoplasty. So we'll document abdominoplasty. Now, I am going to document or inventory our diagnoses, and there are There are a few more. We have a paniculus. We have diastasis recti, history of pregnancy complication, low back pain, constipation, chafing, irritation, bleeding, and infection. All right, so just so you know, paniculus is abdominal fat. Yes. And diastasis recti, this means separation of the muscle. All right, so these are specifically abdominal muscles. So both, these are two distinct procedures. Now, what do we do next? Because we have an operative report, and this is an operative report, we're going to have to go to step 3. And step 3 tells us to document how the surgical site was entered. Make sure we write that down. Is this procedure open, closed? Were there any additional procedures? So we know that we have an abdominoplasty, and I did highlight some things that are pertinent. That there was an incision. This is an open procedure. Yeah, we know that, right? But I still wrote it down. Also, disc of skin was removed and deep dermal repair. So what does this mean? Well, can we code them all? Well, not necessarily. If they are integral to an abdominoplasty, then no, we can't code it. So how do we know? Well, this is going to take us understanding what the procedure is. What is an abdominoplasty? So I've got an image of an abdominoplasty, and in the first picture, you see where the surgical site was outlined, and then in the second picture, incision is made. So based on these pictures and images, we can just go ahead and cross off incision. Next, disc of deep skin removed. All right, so in the third image, we see a disc of skin being removed. And fourth, that's our proof that it's gone. So we're going to go ahead and remove the disc of skin removed. Oh, I think I said that wrong. And fourth, deep dermal repair. In this fourth image, I don't know if you can tell, but actually the abdomen was sutured together. So this is the abdomen. These abdominal muscles are even more, how can I say? It's more extensive than deep dermal. So definitely, if the abdominal muscles were repaired, the deep dermal, it definitely falls in that category. So I would say that the only codable procedure is abdominoplasty because the others are integral. Now, let's go and look up our procedure in CPT. So if you go to the index, the CPT index in the front of CPT, you can look up your procedure in alphabetical order. So we begin with A, you see abdomen, abdominal, and then if you go down, you see abdominoplasty. There you go. So underneath it says excision of skin and tissue, and then it leads you to codes 15830 and 15847. And the other option is an unlisted procedure, 1799. Well, I don't think this is an unlisted procedure. I'm going to go look up the codes that they've provided. So if we go to the chapters, that's the color pages, and you look up 15830, this is the code for excision, excessive skin, and subcutaneous tissue, includes lipectomy. And this is for the abdomen, infra-umbilical paniculectomy. All right, so this pretty much says some of the procedure. And the reason I'm saying some is because it does not account for the muscle. It's saying excessive skin and subcutaneous tissue, and it's pretty much removal of that, but it's not coding for that repair. So it tells us to go to 15847. This is excision. Excessive skin and subcutaneous tissue includes lipectomy. Same thing, these are both the same, except this is excessive, and it says abdomen, abdominoplasty. Example, abdominoplasty includes umbilical transposition and fascial plication. All right, so they're getting down. The fascia is the it's the tissue around the muscle. So our index told us that both of these codes are our codes, and I have to agree that they are. And also, don't forget to look at your parenthetical guidelines. It says for abdominal wall hernia repair, you do something else. To report other abdominoplasty, use that unlisted procedure code. I believe that these two are sufficient, and therefore I am going to deduce that they are correct. So we're going to just finish up our little chun, circle our families. Our correct answer, 15830 and 15847, which is our add-on code, and we certainly know that add-on codes get coded after the primary procedure. All right, so to select the first listed ICD-10-CM code, I'm going to use my MCG manual, and I'm going to turn to the chart for selection of the first listed code. And if you were in part 1, CPT course part 1, you should have seen this chart and you should know how to use it. However, let me refresh your memory. This first listed code selection chart has 10 columns, and each of the columns have a category. And beneath the column's category is the guidance for that circumstance. So if you have a sign and symptom in your documentation or your inventory, your guidance is below. So these signs and symptoms, any sign and symptom in documentation can be first listed when no other diagnosis is present. So we can see that we have some diagnoses present. So let's look below. Our guidance says, do not code signs and symptoms when they are integral to a codable diagnosis or diagnoses, yeah. So if we look at our signs and symptoms, you see number 4, this is low back pain. And I kind of got ahead of myself and it's crossed out because low back pain is integral to panniculus. Panniculus, remember, is fat, excessive fat. So if a person has excessive fat, low back pain is likely. Oh, I wouldn't say it's likely, but it's not unlikely. All right, constipation. Yeah, so if you have excessive fat in the abdominal area, that could be the cause of constipation. Chafing, panniculus is a indicator, chafing is an indicator of panniculus, and so is irritation, and that could lead to bleeding and infection. So all of these Chapter 19 codes, I'm saying Chapter 19 because there are codes, that's a clue, are integral to number 1 and or number 2. So that leaves us with 1, 2, and 3. specifically number 3. Number 3 is history of pregnancy complication. So I indicated that pregnancy of complication, that this circumstance is a result, or is these are resulting from a pregnancy complication. So if we go to number 5, I'm going to go seek some guidance. Number 5 tells us that when you have coexisting conditions, code all documented conditions that coexist at the time of the visit or conditions that affects the patient's treatment. All right, so pretty much these two diagnoses were they both coexist. So we know one is going to be first listed and the other will be secondary. So we know we're going to code both of them. And below that guidance, it says do not code resolved conditions. And below that, use history codes for past diagnoses pertinent to the encounter. All right, so we do have a history code, and I believe pregnancy complication should be coded because it is pertinent to the encounter. How do I know? If we go back to the documentation, you will see that the clinical note says that diastasis recti occurred with the last pregnancy. The provider or the surgeon is connecting this condition with the last pregnancy, so that means that this is a pregnancy complication. And if you can recall your chapter 15 guidelines, you are to use these pregnancy complication codes if it is still in the puerperal or during the pregnancy period. But this is not during that period. There's no indication that it is. And we are going to code the history, the personal history of a pregnancy complication. And now we have to determine what is your first listed code. Well, I can't determine what the first listed code is because if we go to number 2, outpatient surgery, and we're going to assume this is outpatient. There's no indicator that this patient was admitted. So this is outpatient surgery. It says code the chief reason for the surgery as the first listed code. And boom, the chief reason for the surgery could be paniculus or diastasis recti. So I just chose one. I chose diastasis recti. That is my first listed code. If you've chosen paniculus, you are correct as well. Now here are my codes: M62.0, E65, Z87.59. Now we have to go to the third step and we have to apply all guidelines. Where do I get my guidelines? I go right into the MCG manual, and it says that there are no coding guidelines for either of these CPT codes or these ICD-10-CM codes. So here is my final answer. All right, so this is how you solve a case. After you do your highlighting, your keyword concept, number 1, inventory or write down all procedures, diagnoses, signs, and symptoms. Number 2, go ahead and select the principal procedure. However, if you have an operative report, make sure that you've documented or highlighted how the surgical site was entered or how that patient was lying. Is that procedure open or closed? Any additional procedures, minor or major. And then you can select your principal procedure. Then number 4, select your first listed ICD-10-CM code. If you need to, go ahead and use the first listed code selection chart, and that can be found in the MCG manual. And if you don't have one, you can go to the AMCI website, amcicoding.com, to go get it. And 5, apply all guidelines. All right, coders, it's up to you. Take it away.